Well, good afternoon. Welcome to this session of CTSNet at EACTS in Barcelona, October 2012. My name is Michael Mack from the Baylor Healthcare System in Dallas, Texas, and today we are discussing what is the ideal CABG. We have a very distinguished panel joining us for this discussion. And from my far left here is Tor Sunt, who is Chief of Cardiac Surgery at the Massachusetts General Hospital in Boston. We have Philip Cole from the University of Liège in Belgium. We have Ivy Mudreau from Aarhus in Copenhagen, Denmark, and Johan Bonatti from the Cleveland Clinic, Abu Dhabi. Welcome all of you. So, our session, as I mentioned, is the ideal CABG. But we hear very many times from our cardiology colleagues that CABG really hasn't changed over 25 years. We do one artery, 3 veins. Most of it's done off pump. We've had a number of advances from robotics to off-pump surgery to all arterial grafting, but it's very seldom used by most of our colleagues nowadays. So let me start by asking each of you, what is the ideal CABG today? And we'll end up this session by asking, what will the ideal CABG look like 10 years from now? So Dr. Sunt, may I start with you? What do you think is our ideal CABG today?
To me, the most important aspect is that we use as many arterial grafts as possible. So I think it's complete arterial revascularization. There are a variety of strategies to accomplish that, but I think the brief answer is complete arterial revascularization with both internal thoracic arteries.
But why is the adoption rate so low? If you look at use of bilateral internal mammary arteries in the United States, it's about 7%. In Europe, it's 15%. Why is that? Well,
it's certainly a harder operation to do. Takes more time to take both mammaries down, both internal thoracic arteries down. There have been concerns about sternal wound infection, although I'm quite convinced that if you take the grafts as skeletonized grafts, the risk of sternal wound infection is not significantly elevated. But it's still a harder operation to do. From a technical standpoint, it's more challenging. And I think that that's the main barrier. It's ease of use, if you will. That's what the manufacturers would call it, ease of use.
So Philip, you're one of the authors of the European guidelines on CABG. What do the guidelines tell us we should be doing?
Well, if we refer to the guidelines that were published 2 years ago, they are right in line with what Dr. Sunt said. I mean, full arterial grafting, whether it's possible. If I'm correct, that was a 1C recommendation because we don't have enough data to have, randomized controlled trial to support that evidence. At least, obviously, one internal mammary artery, that's 1A, and then as many arterial grafts as possible, especially when the patient has reasonable life expectancy. We didn't put a precise number for this value because we don't know. But obviously, with the patient getting older, this is an important point and can be increased. The second is probably try to reduce the manipulation of the aorta. Again, when you get with older patients, you get more aortic diseases. So no touch technique whether it's possible. Maybe off-pump techniques. We probably don't have enough evidence yet to know whether there really is a benefit over the long term, but probably. So that's where I would consider where nowadays the ideal CABG is. Now, obviously, this is from a technical aspect, and we probably, during the discussion, should also talk about the follow-up of the patient.
So, Ivy, you have an intense interest in hybrid revascularization. Now, this is a concept that has been around since the middle 1990s, and I actually at that time was fairly enthused about it, feeling that you took the best of both worlds. You had the advantage of a minimally invasive lima to the LAD, and if we're going to use vein grafts to the other vessels, why not just put stents in? And it never really gained traction for a whole host of reasons, but now there seems to be a lot of interest in this again. Can you perhaps tell us what your experience is and why we're revisiting this old concept that didn't really take off before?
Well, there isn't much of a question that the guidelines recommend coronary revascularization by surgery in a vast majority of patients with multivessel disease and 1 and 2 vessel disease when the proximal LAD is involved. But the adherence to those guidelines are very, very low. We looked at our data in Denmark and we realized that 60% of all patients with multivessel disease alone were treated by PCI. And of course we may accuse that's the cardiology withholding the patient from the conference, from surgery, or we can accuse ourselves not to have reduced the risk by all these advanced techniques we have. But we have to consider as well the patient has a wish. We have to address that there are patients with high risks that are not in this table, famous table 9. So we have to have another possibility to offer. And we are very convinced that the major issue in this context is to establish a heart conference where every patient is brought into discussion. That this is the major problem with the guidelines, that when the patients don't come to discussion, we can have the best treatment. It will never reach the patient. And for us, it appears that hybrid treatment can be the missing link in this context. And we have tried to establish a hybrid technique that is addressing the problem with the difficult technique. We use a lower sternotomy, which enables to use completely standard off-pump techniques with fantastic exposition of the heart, no special technique, no steep no learning curve problem. And we think when we find a technique that is applicable everywhere, then it would be to the benefit of a lot of patients more than it is the fact today.
Johan, you gave a wonderful presentation earlier today at Techno College here at the meeting about your experience with robotic CABG, and clearly you are the pioneer in this area and have more experience than anybody in the world. Is robotic the ideal CABG?
From my perspective, yes, of course. It is a goal, I think, that many heart surgeons should at least pursue. One thing is clear. I would like to see in the ideal CABG a significant reduction of the surgical trauma. That matters to the patient, that matters to us, I think. And robotics is so far the only way to achieve a totally endoscopic approach to CABG. The laparoscopic cholecystectomy has clearly taken over in general surgery. I see no reason why in heart surgery CABG in the near of our future should not be performed in totally endoscopic technique. We have the tools, we have the techniques, and I think if more people come on board, we can bring it on a broad basis.
How many centers are there worldwide that are routinely performing totally endoscopic coronary bypass?
At this point, probably in the 10 centers range. We have one day calculated how many surgeons have ever tried a TCAB, and that number is something like 35 surgeons. Some of them have left the technique for various reasons, not only because the results were bad, but there were also financial aspects or just logistics of getting the program rolling. There are all these centers that I mentioned are extremely dedicated. Those centers will have come a long ways, and they will certainly continue with the technique and bring it further along.
Tor, I actually heard something this morning that I never thought I would hear, and that's Professor Taggart states that the graft patency may be less off-pump than on-pump. What's your opinion about that, and where do you see the role of off-pump surgery?
I recorded that and noted the time and the date of that statement as well. I was struck by that. To be honest, do the vast majority of my coronary bypass on pump. I'm happy with that technique, and it seems to work well for me, and I think the most important thing is the long-term outcome. I think that the trade-off of durability for invasiveness, we're more invasive than PCI, but we're more durable, and I'm very reluctant to give up on any durability for the sake of the invasiveness aspect. I acknowledge where you're going, and I'm sure that 100 years from now they'll look back at what I do and think I'm a terrible barbarian for doing it. But for right now, I'm concerned even about a small increment in decline in patency rate for off-pump surgery.
Is there any patient that you feel should get off-pump surgery?
So in elderly patients that are at particularly high risk of stroke or renal failure, especially if the only graft they need is a graft to the LAD, I'm quite happy to do that. I think that there are selected patients in whom the benefits of off-pump outweigh the downside. But all of these techniques, I think, should be considered complementary, and it's just a matter of tailoring the specific technique for the specific patient.
So, Philippe, we have guidelines in place that are evidence-based, yet compliance with the guidelines is very low, specifically regarding arterial grafting. How do we increase compliance with the guidelines?
Well, it's a very important and a very difficult topic. I think one of the most important aspects of these guidelines is the introduction or the emphasis of the heart team. That's only by working with our friends and colleagues, the cardiologists, that we will be able to, I think, implement these guidelines. And we should remember that the heart team is supposed to have a cardiac surgeon, an invasive and a non-invasive cardiologist, which we know is not always the case, to put it mildly. And in numerous instances, probably we should take more time to discuss with the patient, and a discussion and a decision within a few minutes while the patient is half asleep on the cath table is not the right time to take a peaceful and thoughtful decision. So if we give more time to think about that, I think it's quite important, and we can explain to the patient, to the patient's family, sometimes to the GP and other practitioners, what are the possible techniques for this particular patient. And we know that in this table 9, it favors CABG in a lot of situations, but also, for example, for patients with 3 vessel disease and a low syntax score up to 22, both options, 1A on one side and 2AB for PCI, is very reasonable. So if the patient is high risk, that's fine, but we should discuss and explain why the PCI is associated with higher recurrent disease. I think it's very important, the concept of the heart team, to implement the guidelines.
So, Ivy, we actually have 3 important trial results this year. We will have the FREEDOM trial, which is a randomized trial of CABG versus PCI in diabetics that are presented at the American Heart Association meeting in 2 weeks. But we've already had 2 very important trials, the 5-year results of the Syntax trial and the ASSERT trial, and both of which show a very significant mortality benefit. The Syntax trial at 5 years, the ASSERT trial at over 2.5 years. Do you see the pendulum swinging at all based upon this evidence back toward CABG in multivessel disease?
Well, unfortunately, I think the major problem still is that a vast majority of patients don't come to our attention, so they don't get the offer. And in our experience, it has been a very good process. By doing hybrids and working very, very close together, we get to know each other, we get to know our principles, our possibilities, and for example, the incidence of a Lima to LAD as a single procedure by surgery has increased dramatically at our institution as a consequence of doing hybrid treatment. And well, the table recommends Lima to LAD, but as I talk to colleagues, no one ever does it because it's done in the cath lab. And if we can achieve to get more patients to our attention, that would be very desirable, after my opinion.
So how frequently do you do hybrid procedures, and have you seen an increase in volume of this approach in your institution, or the proportion of multivessel disease patients being treated with hybrid procedures?
Well, we have decided to do hybrid treatment only in very special situations as a routine treatment. Most of the patients are otherwise included in a pilot study. Now we're starting the second one. That is planned randomized controlled trial, because we want to have some evidence, because otherwise we can just keep on saying, well, I think it is. We have to have proof. So.
And the randomization is against multivessel surgery or multivessel PCI or both?
Multivessel surgery versus hybrid treatment is the plan. But now we have done the first 100 patients in a sequence, and now we do the next 50 in one step to decide which one we would prefer for the randomized trial.
So, Johannes, we heard a couple of very interesting presentations this morning about the use of external mesh around vein grafts. The rationale being is, despite all the evidence and the recommendations of all arterial or at least bilateral internal mammary arteries, the overwhelming majority of grafts still put in are saphenous vein grafts. What's your opinion of this external mesh of turning a vein into an artery, if you will? Did you have previous knowledge of this? Are you enthused about it? Do you think that this is a significant advance?
In fact, I do have experience and knowledge about that, as I was working on vascular biology of vein grafts earlier in my career. We had a lab where we did vein graft models of vein graft neo-intimal hyperplasia in vein graft culture models, also in a quite difficult mouse model. And the external mesh at that time already was something proven. It definitely works. If you do a mesh around an arterial implanted vein graft, it definitely leads to reduction of neo-intimal hyperplasia. We even had the thought that you could put anti-proliferating agents on these meshes in order to reduce the neo-intimal hyperplasia even further. To be honest, I don't think we should go that route. I think we should work on better methods to use what is there, what nature has given us, 2 IMAs and the radial arteries. The external mesh is not something that I will pursue.
So, Tor, there seems to be a trend towards super subspecialization in cardiac surgery. We have our mitral valve specialists, we have our aortic valve specialists, we have our TAVR specialists, we have our thoracic endografting specialists. Do you think we should treat coronary revascularization as a specialty? Because until now it's something that all of us do. Do you think that we're missing an opportunity to improve coronary revascularization by not having designated specialists do it?
I think there's no doubt that a procedure is best done by someone who has an intense interest in it, in the finer points of it. We have to separate in our minds from in our egos the question of do you know, are you capable technically of doing a procedure or not, and acknowledge that those among us who have a particular interest in an area will do a better job just because that's where their interest is. And I agree with your thesis. I think that would increase the percentage of patients who had complete arterial revascularization. It would increase the use of bilateral ITAs. In our experience, if you look in each of our institutions, I'm sure it's not that every surgeon uses bilateral ITAs 5% of the time. It's that one surgeon uses bilateral ITAs 70% of the time and the other surgeons don't. So that's de facto a form of super specialization. And I agree with the idea that we should steer cases, or cases should be steered towards individuals with a particular interest. And we should respect a coronary bypass. The problem is it's so common, but it's such a remarkably effective operation. It's just incredible how it extends people's lives, and now being able to show how it stacks up against PCI. We shouldn't take coronary bypass for granted.
So I promised at the end of this or at the beginning of this, that by the end we would talk about what CABG will look like 10 years from now. So I guess the first presumption is that CABG will still be around 10 years from now. I remember a debate with Professor Sarais in 1999 that he promised that CABG would be dead within 10 years. Well, clearly it's not. So let me start with Johannes, and we'll work our way down the panel and end it with Dr. Sant. What do you see CABG looking like 10 years from now?
Okay. In 10 years from now, CABG will certainly exist. I see a trend already in the increase in hybrid procedures. That trend, I think, will hold, and I think that a significant number of procedures will be done in the hybrid concept, which of course includes less invasive approaches to sewing the lemur to the LAD. I would also suggest to work very hard on the option of putting both IMAs in a less invasive fashion to the left ventricle, because that's what we noticed. If you do lemur to LAD and stenting, if you look for those patients, you have probably a segment of 10 to 15% out of the CABG population. If you can do double IMA in less invasive or completely endoscopic fashion and combine that with PTCA and stenting, the spectrum opens to about half of all patients.
Ivy, what's CABG look like 10 years from now?
It's difficult to say, but I agree. I think hybrid procedures will be a very central portion of the treatment offered. But I think the most important issue is that we keep this heart conference concept very much up, and that we extend our communication and collaboration with our cardiology colleagues to find an individual solution for every patient. I don't think there's the ideal bypass. I think our patients are individual, and we need to take care of different aspects of their disease, of their comorbidities, that maybe not one operation will fit everyone. But it would be nice to have a wide range of options that we can choose for our individual patients.
So Philip, you're now writing the update of the 2022 guidelines for coronary revascularization. What are you going to write?
I don't know yet. We're just starting the 2014 second version of the guidelines, so that will be probably the fourth or the fifth one. I think CABG will still be performed 10 years or 15 years from now. I suspect less so that now, or less than 10 years ago, probably because we'll have more advanced stents and other techniques. So I think we really will have to refine our technique to use arterial graft, to go with the heart team concept more and more, to use hybrid technique probably, and try to be as effective as possible and as efficient as possible. And again, I fully support the heart team concept.
Thor, you have the final word.
Well, it's hard to add much to that. I think the most important aspect is what Ivy mentioned, that each patient's different. The solution's going to be different for each patient, and that's the way we should regard them. Every patient shouldn't get the same operation. They should get the right operation for them. For some it'll be robotic, for some it'll be hybrid, for some it'll be open.
Well, I'd like to thank this expert panel. It's been an extremely informative discussion of the current state of coronary bypass grafting and where we're going to go in the next 10 years from now. And we certainly appreciate CTSNet allowing us to have this session here in Barcelona at EACTS. Thank you all very much.